So the question we are asking ourselves is that implants in glaucoma, are they overrated? So as we've already seen, trabeculectomy is celebrating its 52nd year. It is still the gold standard as far as glaucoma surgery is concerned. So what's the need to look for an alternative? It's refractory glaucomas, which do not respond to medical or surgical treatment. And the peculiarities of this involves deranged anatomical configuration, physiology, and dynamics of the aqueous circulation. So the first and foremost thing is to understand why will a trab not work in these conditions. So it does not work when the conjunctiva is scarred and if the inner ostium is likely to close, which happens very frequently in these conditions. Why would an implant work in such situations? It's because the tube goes beyond the angles. We get a Tenon's bleb away from the limbus, and the internal tube keeps the ostium open. GDDs can be used as a secondary procedure where GFS has already failed, or as a primary surgical modality where it's reported to have a disappointing outcome. So it was designed to divert the aqueous, and you would be surprised to know that in 1906, horsehair was the first implant that was used to divert the aqueous from the anterior chamber. Molteno in 1969 devised the first GGD, and it has undergone many modifications since then. So what does it have? It has a tube, a drainage, a plate, and a valve. So this valve opens and drains the excess fluid out of the eye. So this is how it looks. This is the FP7. What determines a smooth outflow is the same principle which helps aeroplanes and birds to fly. It's the Bernoulli's phenomenon of continuity. So the kinetic energy is inversely proportional to the potential energy. Potential energy depends on the cross-sectional area. So higher the cross-sectional area, the higher will be the potential energy and lower will be the speed. So how does it work? This is the trapezoidal frame of the valve, and the increased exit velocity helps to evacuate the fluid with minimal valve friction. So I have this case which was published recently, and it's a case of 34-year-old male who had undergone a penetrating keratoplasty, had already undergone trabeculectomy and a cataract surgery, and he was one-eyed. The BCVA was 2630 and the intraocular pressure was 40 on maximum therapy. B scan showed complete PVD and OD was absolute. So a one-eyed status, young age with poor IOP control on MMT necessitated an urgent surgical plan. We had two options, either to go with retrab or to go with AJV. So because of these factors, we thought of going ahead with the AJV. So it was planned in superior temporal quadrant with a hybrid 2025 gauge PPV and placement of tube in the vitreous cavity. So I'll just run the video quickly. This is how the eye looked. This is the corneal traction suture. The conjunctiva is opened, cautery done. The AJV is primed and is placed in the conjunctival pocket. The plate is sutured to the sclera, and this is the vitrectomy being done. So the lower one is infusion cannula with 20 gauge needle, and the superior ones are 25 gauge cannulas. So complete vitrectomy was done with base excision. And the fourth suture, the superior ones, the tube was cut, inserted into the vitreous cavity. So the 1 day post-op pressure was 10, and the tube was visible in the anterior vitreous cavity. And it was maintained at 4 months as well. So this is another case of a 60-year-old male who was a diabetic, vision was 2400, high pressures on maximum therapy, and there was florid neovascularization of the iris with 360 degrees sanical closure. So fundus evaluation showed an ischemic CRVO, PRP was done, still the pressure did not come down. So we planned an AGV in with the tube in the sulcus. So this was the only difference, the entry at the sulcus and the tube, you can see it sitting nicely at the sulcus. The pressure was maintained and the vision improved. So there are other indications, as was mentioned, ICE syndrome and uveitic glaucomas, where it really helps. So what's the verdict? Is it really overrated? I think no. It is of real benefit where the traditional, conventional methodology doesn't work. So there are newer microinvasive implants which we've already seen. So they can be used for mild to moderate glaucomas, and it decreases definitely reliance on medications without the safety risks of more invasive procedures like AGV. Thank you so much. Do we have any questions from the house? I think the next speakers are here. So thank you for being a part of this IC. And we had some great exchange of ideas and some nice discussions. Thanks a lot. I invite the next speakers on the podium. Thank you.